very much. And I will be sharing the screen.
Yes, we can see your screen now.
Okay, can you hear me?
Yes, we can hear you.
Just fine? Okay.
Yeah, we can hear you and see your slides.
Thank you very much. Good morning, everyone. Today we will be talking about reversible cerebral vasoconstriction syndrome. This is an article we published in 2019. We published it in Spain in Revista de Neurología. And it's a very interesting case report, as you will see during the presentation. First, to get going, we have some key points. This is a low incidence disease which has a multifactorial etiology, and it diagnosis is based on clinical findings and angiographical findings that I will show you later. Definitely the main symptom is thunderclap headache that might or might not come with neurological symptoms. But the main characteristic is this thunderclap headache. In 2007, Dr. Calabrese and his teammates they proposed this criteria that we still use them actually. Are those that you're looking at in the screen. Basically, you have to have some clinical findings, and in the angiography, you have to have reversibility or angiographical abnormalities that resolve within 12 weeks of symptoms onset. It's important that reversible cerebral vasoconstriction syndrome has no evidence of aneurysmal subarachnoid hemorrhage, but can have subarachnoid hemorrhage, so that is a very important key point. And for the differential diagnosis, you have to have in mind that the cerebrospinal fluid can be normal or near normal. In the etiology, we have pregnancy, puerperium, vasoactive substances and medications, the use of some medications. You can have migraine, and of course unknown etiology. This is a rare disease or a very infrequent disease where we don't have all the etiologies described, as you will see in this clinical case. About the treatment, there is no sufficient evidence about an effective therapy for the disease, but definitely calcium channel blockers such as nimodipine and verapamil are the most used drugs for clinicians. There's some evidence of endovascular therapy, especially with the intraarterial administration of nimodipine during a crisis, and the key point to treat this condition is to identify and to treat the underlying cause. Let's start with the clinical case. The patient's background, is a female, a 71-year-old female from Colombia. She lives in Bogota, which is the capital of Colombia, and she is a retired fisher. In the admission, 1 week prior to the admission, she had a sudden manifestation consisting of dysarthria, anterior aphasia, drowsiness associated with thunderclap headache, thunderclap and left-sided hemicranial headache lasting 2 minutes. That self-resolved, and in that moment, the doctors that saw her in the emergency department thought that the clinical suspicion was a transient ischemic attack. With all the studies, and all the studies were normal. The MRI, the brain MRI was normal. The CTA of the neck was normal, and the echocardiogram was normal. 1 week after, she came back to our emergency department with the same symptoms, lasting 1 hour. She had history of breast cancer treated with Anastrazole with a dose of 1 milligram a day, and additionally, she presented with high blood pressure that as you can see on the screen. The rest of the vital signs were normal, and the neurological exam showed drowsiness with anterior aphasia and multiple language blockages. At that very moment, we decided to perform an MRI that showed left insular cortex, a left insular cortex infarction with subarachnoid hemorrhage and no evidence of venous sinus thrombosis. That was one of our main concerns in this patient in the context of a severe headache. As you can see on the screen, those were the imagenological findings. Here in this one sequence of the MRI, you can see the subarachnoid hemorrhage, the parietemporal subarachnoid hemorrhage. And during the parenchymogram, you can see that the feeling was insufficient in the brain, and we decided to administer 4 milligrams of intraarterial nimodipine with subsequent restoration of the vessel caliber of the anterior cerebral artery and the middle cerebral artery territories, with a good clinical outcome during inside the OR. The patient was aphasic when we performed this procedure, and once we administered 4 milligrams of intraarterial nimodipine, the patient got back to her normal basis. What happened next? During the hospitalization, she presented 2 episodes of language impairment with facial asymmetry, sensory symptoms, and right-sided hemiparesis, for which therapeutic angiographies, as I showed you before, were performed with good clinical outcomes. In the three times we performed an angiography, a therapeutic angiography, we administered 4 milligrams of intraarterial nimodipine with good clinical outcomes, as I just said. After ruling out other causes and evaluating the patient's risk factors, the use of Anastrazole was suggested as the possible etiology of the disease. This drug was discontinued, and no new episodes were seen until now. The patient right now is perfect. The patient continued with 30 milligrams every 12 hours of nimodipine for 3 months, and 6 months after the MRI showed no evidence of cerebral infarction. In the discussion of our article, this is the angiography of our patient. As you can see, this is the classic pattern of reversible cerebral vasoconstriction syndrome. Here you can see vasoconstriction in the anterior circulation, anterior and posterior circulation. You can see here vasoconstriction, here, and here. And she came to the emergency department with the classic clinical presentation consisting of thunderclap headache and recurrent multifocal neurological deficit. And it's important to note that she came with subarachnoid hemorrhage, no aneurysmal subarachnoid hemorrhage. Finding the etiology in the exercise of finding the etiology of this patient, of the disease of this patient, we took in count that she had a history of breast cancer. We reviewed the medication that she was taking, and with that, we performed a review of the literature and the possibility of alternative diagnosis. A vasculitis was one of the main differential diagnoses, but the cerebrospinal fluid was normal. So we were pretty concerned that this patient had reversible cerebral vasoconstriction syndrome. And the Anastrazole was the medication that mainly concerned us. This is an aromatase inhibitor and is useful in some types of breast cancer. It interrupts estrogen synthesis and suppresses the growth of those tumors. But why was Anastrazole considered the underlying cause? Basically, when we reviewed the literature, we found the ATAC trial that showed that the anastrozole was linked with some cerebrovascular events. They did not specify what kind of cerebrovascular events, but possibly they were strokes or something like that. They described that the cerebrovascular events with anastrozole was 2% versus 2.8% in the tamoxifen group. There is no evidence linking anastrozole to RCDS, but the most likely etiology was the use of medications. She only used losartan and anastrozole, and losartan was not linked to any vascular events. So, although the incidence of RCDS induced by anastrozole is 0%, the clinical improvement after drug discontinuation, along with the absence of new events, suggests that anastrozole might have been the trigger of the disease. And for the conclusion, RCDS is a diagnostic challenge given its variable presentation and its multifactorial etiology. As I just mentioned in the beginning of the presentation, the first thing you have to do when you have a patient like that is to identify the underlying cause and treat it. If you do not do that, the patient might have more possibilities of having worse clinical outcomes. As you saw, once we had the clinical suspicion that anastrozole was the cause, we discontinued the medication and the patient did not have any more events. And it's important to know that a large variety of medications have been associated with RCDS. Many of those have a prolonged period between drug exposure and disease onset, but this is really unclear. We do not have the sufficient evidence to say that. And of course, this is only a case report. We cannot create a direct relationship between anastrozole and RCDS. So any case similar to this one should be reported for pharmacovigilance. We got in contact with many industries, pharmacovigilance industries, and we presented our case with them. So it's important that when you doctors have a patient with RCDS associated with any medication that is not described in the literature, it would be very interesting to publish it because our patients can have benefit of that. This is our neurovascular research group from my university. Our leader is Dr. Juliana Coral here in red. And we have many published papers about this disease and cerebrovascular disease. And this is our university, and this is the hospital I work for nowadays, which is called Fundación Santa Fe de Bogotá. And this is my email if any of you want to get in touch. And thank you very much.
Thank you so much for your really interesting talk. We have a question in the text box from Raul saying, do you think that this could be an isolated case, or your advice would be to take care with this medication, specifically in our Latin American population?
Well, here in Latin America, we use a lot anastrozole. It might be only an isolated case, without doubt, but definitely you have to take in account that when you have a patient with breast cancer using anastrozole that comes to your consult with thunderclap headache, you have to think in RCDS because it might be the underlying cause of that headache.
Thank you. Are there any other questions? So has the patient got any are there any sort of permanent neurological damage, or are they fine now?
No, she's just fine. She's fine. Yeah. We see her every month. I just talked with her yesterday, and she is perfect.
Okay.
Yeah, she did not have any new events with that.
Any more questions, anybody? If you do have any questions, feel free to email the speakers directly, and you can ask them if you think of any questions when you finish today. Feel free to contact the speakers directly if you think of anything later on. So on that note, I think we're going to say thank you for your talk. Thank you, Andres. And I think we're going to pass over. Thank you. I think we're going to pass over to the organisers now. So thank you, everybody. Thank you to all the wonderful speakers that we've had today. We've seen a really high quality research and lots of really interesting work that we hopefully will see published very soon. So thank you very much, everyone.
Yep, great talks, isn't it? And appreciate all speakers for their time and the presentations, and I hope it made a great knowledge transfer. And Dr. Terry, thank you very much for moderating the session, make it interactive and on time as well. Hope you enjoyed it, and it's an honor working with you. So that's it for the day one. Let's meet tomorrow at 7 a.m. EST for the next set of sessions. Thank you. Good evening. Have a nice day. Bye-bye.